Here for a Deuk Laser Disc Repair. Our patient has a herniated disc at L5-S1. He's got back pain and left leg pain, among other radicular symptoms down the left leg. Radicular symptoms are symptoms like numbness, tingling, weakness in the leg or arm. Radiculopathy is not specific to the cervical or lumbar spine. It just refers to a problem with the nerve root. It could be in the cervical spine, which is your neck, or it could be in the lumbar spine, which is the lower back. Lumbar radiculopathy refers to a problem with the nerve root in the lower back. Cervical radiculopathy refers to a problem with the nerve root in the neck or cervical spine. The nerve root. Sir, are you ready to get started? Dr. Deukmedjian here, okay? I'm going to be talking to you and some people as well, the audience that are watching and my team. Are you comfortable where you are? Understood. We're going to get rid of that for you, but I need you to lay still during the surgery, okay? If you feel anything that hurts, don't try to move. Just say ouch and I'll give you some more pain medicine. Deal? All right. We're going to get started. Yeah, that's my hand on your back there. I'm just feeling around. All right, you comfortable? I'm going to give you a little medicine to get things going. You'll feel a little stick and burn. It'll just be for a few seconds. It'll get better, okay? You're doing great. Everything's okay. That's just the numbing medicine going in. All right, so radiculopathy means a problem with a nerve root. And there's nerve roots in the neck, nerve roots in the lower back, and that's it. Well, of course you have thoracic nerve roots, but nobody ever has problems with those. It's very rare. So 99% of nerve root problems happen in the neck or the lower back. In this patient's situation, the herniated disc is coming out and it's either pushing on or irritating his nerve root going down his left leg. All right, we're getting started. Let me have some numbing medicine. So in this patient situation, to kind of boil things down to what they are, we're basically treating his back pain and his radiculopathy, which is the nerve problem, pinched nerve problem. This is the way most people hear about it or think about it. We're treating them both with a surgery designed to fix both. Shot. And the reality is that most people that have problems with herniated discs, they either have back pain, leg pain, or both. In his case, he's got both. Shot. Give me a lateral, please. Now, the L5-S1 disc, the one we're fixing today, that's herniated, this is the second most common disc herniation there is. And I need the table down a little bit. Stop. Now you can see the patient has spondylolisthesis as well. That's where the bones are slipping on each other. So he's not going to make it easy for me by any means. This is a really tough one to get. Well, we're going to do our best to get in there and get it done. Are you comfortable? About as comfortable as you can be, right? Laying on an operating table. Shot. So you can see the needles coming in. And I'm not fixing his spondylolisthesis. We're only fixing the source of the pain, which is not the listhesis. Most people that have pain in their back, it's coming from a disc problem. Shot. I believe his pain is coming from his disc. And the disc just happens to be where there's a listhesis. Shot. AP. So most surgeons would look at this patient's back. You can see on the x-ray the L5 is slipping on the S1, and they would say, oh, the problem is the bones moving and slipping on each other. But that really is not the problem. The reality is lateral. The problem is the herniated disc that's between those slipping bones. That disc is the source of the pain. The bones themselves don't hurt. There's nothing wrong with his bones, except that there's probably a fracture at L5 on both sides. But the bones themselves are not the cause of the pain. It's actually the disc herniation between them that's causing the pain. Everything good over there? Maybe we could drop that a little bit. Okay. Just lay still. You're doing good. I know it's a little bit uncomfortable. Shot. 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 Yeah. And we're encountering really what's a tremendous amount of scar tissue. Is that it?
Yes, sir.
From the fracture, from all. How long ago did your back start hurting you? Shot. Huh? 2 years? Shot. All of a sudden you couldn't? Why not? Your back would start hurting you? Shot. Yeah, you have what's called neurogenic claudication. That's where your nerves are getting pinched. Are you having any pain right now?
Just like a constant sharp pain all the way from the little bit of the back all the way down into the leg.
How far down?
And it goes like the bottom of the butt. You know,
Bottom of your butt, but not down your leg, AP?
no. Guess it's the way I'm laying or something. Just fix it.
Shot. Of course, it's going to be difficult seeing where we are based on the anatomy. Go ahead and go back to a lateral. Everything looks lined up nicely. The needle's where it's supposed to be. It could be a little bit lower than where we are, but let's see what we can do. If I have to reposition, I will. Yeah. I may want to start a little bit higher and come in. Huh? I'm not happy with where it is. Any discomfort? Shot. Let's see if we can. Those pedicles, let's see if we can wag a little bit and just get them better. I don't think we're too far off, to be honest with you. I think we're at most 1 degree. Just wag one way or the other. Let's see if it gets better or worse. That was better, I think. It's hard to say, though. It looks better with some respects. It looks worse in some respects. Let me have the wag. Shot. 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 Come south with the fluoro. So just line the iliac crest back up there. Shot. Shot. I need you to go south with the fluoro. Shot. It's interesting, isn't it? Shot. Shot. Did I overshoot on the crest? No, I overshot on the crest. Probably shot. Shot. All right. Well, let's lock it there and see what we can do. The pelvic area is a little bit off. Are you comfortable? Are you comfortable? In your back. All right, bear with me. But not down your leg. Let me know if you feel anything down your leg. Nothing? Shot? Where are we at? Huh? That's good. That's good. I don't want you to, but if you do, let me know. See if we can get him to relax just a little bit. But I need him awake. Yes, I know it is.
I have a question, Dr. Deuk.
Sure.
This is from Phil. Have you ever seen listhesis displacement worse without paralysis?
Have I ever seen listhesis displacement worse without what?
Paralysis.
Yeah, this is a grade 2 slip. You usually don't get paralysis with a grade 2 slip. But grade 2 is kind of pushing the limit. I mean, once you get past 2, you get to 3, people usually have a lot of weakness as a result of that. How's he doing? All right, what was your question? AP? A what? A fracture of the pars? Yeah. Yeah, there's a pars fracture. I believe there's a pars fracture, yeah. We call it a pars defect. It is a fracture, though, for the most part. That's what it is. All right, that's good. Back to a lateral. Are you comfortable? Shot. So we're right there. Let's try to wag a little bit. Release the wag. Shot. That seems to be better right there. Lock it in. All right. Are you still comfortable? I'm not happy. I want to probably have to come in a little bit higher up. Let's have some skin numbing. You're taking too long. Just let me grab it next time. I don't need a ballet of instruments. Shot. 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 Any discomfort? Shot. Huh?
Those ones you were doing just before the last one,
Yeah.
I could feel it, touching whatever it was. There wasn't no sharp pain, but I could tell you were there.
Yeah, I was close. I'm not as close yet, but I will be in just a second. Shot. We're right at the back of your vertebrae. Any pain? Yeah. I understand, but nothing new. Shot. Right there. Ooh, so close. Um, shot. I'm kind of being diverted up by his anatomy. Again, we're in an area that is very scarred up because of the old injury, the pars defect. Shot. Shot. Yeah. Shot. Shot. And I'm not able to get it to go where I want it to. Let's try one more time. Shot. Shot. Now, worst case scenario, we can work with this, most likely. Shot. Let's get an AP, see where we are. Yeah, it's perfect. So AP looks good. Lateral, we're just a little bit higher than we want to be. We have to probably come in at a higher angle. When you have a listhesis, the plane of the sacrum is usually slanted down in the front. So we have to start higher in the back to get there. Let's go to a lateral. And that's what we're doing. We moved up higher towards the head on our entry point to get lower at the L5-S1 base. I'm going to try one more time. Shot. Oh, we're so close. Shot. 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 And what we're passing through is really muscle. Shot. Which muscle is really hard to injure. So we're pretty safe. Shot. 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 Any discomfort? Shot. AP. Yeah. Again, we're right there, right at the disc, which is good. Let's go lateral. But once again, we're a little higher than I want to be. Shot. Shot. Let's Let's get our blood pressure down a little bit. Shot. 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 Gonna end up in the same place again. Shot. Any discomfort? Where do you feel that? Sir?
Better than it was.
Alright. Shot. Yep. Alright. Let's take the wag. Release it. Shot. 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 Definitely worse there. All right, give me a shot here. Lock it in. We're right at the back of the disc. I think we're as good as we're going to get it. Unfortunately, I'm not going to be able to get in and do a discogram. Okay. You comfortable? We're going to put you to sleep in just a minute, but I want to give one last try to get inside and do a discogram before we get started, but I just don't think that's going to be possible because of your anatomy. But we should be able to get everything done we need to. All right. You get to go to sleep. Go ahead and count from 1 to 100 out loud. There's no discogram. Nice and loud.
5, 6, 7, 8, 9, 10, 11,
You're doing good.
13, 14, 15, 16, 17, 18, 19, 20.
You're doing great. When you wake up, we'll be done. Shot. Keep going. You're doing good. Keep counting. Shot. All right, well, this is the best we can do. It's not perfect, but we are going to use the guide wire to get down to the L5-S1 foramen. And then, shot, I'm going to have to... Huh? Thanks. Blood pressure is where? Can we get that down, please? Shot. So we use the guide wire to kind of get us down to where we need to be, but ultimately, shot. Come on, Jordan. I don't need to have you not doing the shots. This is where I need you to do the shots. Shot? All right. So at this point, we're starting to sneak in just underneath the nerves. Just underneath the nerve root. Shot? Is he asleep?
Yes.
All right. This will be the most stimulating part of the surgery right here. Shot? Yeah. And the key here is just to try to mimic the angle of the disc. Shot? So. Shot? Shot? Good, we're inside. Give me an AP. All right, so again, it's better to be good, lucky than good, right? So what we've done here, for those of you watching and learning, is I couldn't get into the actual disc. Now, I always on lumbars want to be with my needle inside the disc, through the annular tear, in the disc. I put my guide wire down through the needle so I'm inside the disc with the tip of the guide wire. In a few cases where I get listhesis like this, I adjust my angle. I start higher up on the back and I aim more down to try to navigate through that collapsed tight foramen. But sometimes all the scar tissue from the as this patient has a pars defect, which is really a fracture through the pars, probably on both sides. I don't remember what he's got, but there's all this scar tissue, bone, all this stuff that isn't normally there. And the facet is really abnormal. So basically it starts pushing your needle, right? And your needle is kind of flimsy compared to all that bone and scar tissue down there. So the best I could do is get to the back of the disc with the needle and guide wire. I was underneath the L5 nerve root that's exiting on the left side because he didn't have any leg symptoms. So I knew I was under the root. And then I just brought my dilator in there. I planted it under the root, put it right on the disc, and then I just put it in once he's asleep. And by doing that with him asleep, he's relaxed. He's not feeling the pain of the procedure. So his muscles relax in his back, and then allows the disc to open and allows the bones to spread apart. So it allows me to get in easier. And that's what we did. And we just confirmed placement with an AP lateral fluoro. So I'm very happy with our positioning. We're inside the disc now, which is the safe place to be. I just didn't start like that. And that is not a technique for beginners. Trust me. It's a very advanced technique. I do not recommend any beginners do that. You should have at least a minimum of 100 cases under your belt before you do something like that. I didn't start doing it until I had well into the hundreds. All right, you can see the dilator starting to move forward a little bit. So we need to pull this dilator back because it's trapped. There's probably some tissue. Thank you, Luis, but I think we can do without it. All right, I don't want to pull it back too far, shot. But what you don't want to do is advance the dilator into the pelvis, past the front of the disc. And if you're not watching carefully, you'll do that accidentally. Shot. So what I'm doing is I'm advancing the tube and the dilator together. Not ideal, but I can't do anything about it because there's some tissue stuck between the end of the tubular retractor and the tip of the dilator. It's just wedged in there, and it's causing them to, like, I don't know what you call it, a cold welding, where they act as though they're one. Shot. Which they're not. They're obviously two separate instruments. Need to go in a little bit more. I'm going to have to pull the dilator back again. Shot. Because it wants to move forward with the tubular retractor. And I don't want it moving forward. Okay, shot. All right, good. I think we're in. Shot. We're in like Flynn. Shot. Let's just make sure. That's our tubular retractor. I see it now. Yep, we're in. All right, we're in good and far. Can actually pull it back a little bit. All right, let's go ahead and get the scope in, flow out. I'm going to pull this back a little because we're in a little further than I want to be. Come on, let's not do that. What is that? Great. Let's just not do it. What happened to cause that noise? Right, so how can you avoid that? Well, if the cap was all the way on all the way, would it snap? If the cap's on all the way, will it snap? Correct. So if you start with it on all the way, it won't do that. Right? Who knows what root cause analysis means? Anybody here a problem solver? Who wants to tell us what a root cause analysis is? Can you move that IV bag, please? The IV bag. Thanks. What is a root cause analysis? Correct. You find the source of the problem, the root of the problem. And do what? Fix it. That's right. You fix it. If you find the source of the problem, you're only halfway done. You have to solve the problem so it doesn't keep happening.
How it looks like. This is the one that we repaired, that we sent it.
The scope?
Yeah. I just want to make sure it's fine.
I think it looks pretty good. There we go. How did I discover the cure to back pain? I found the root cause of back pain. And once I knew the root cause, which nobody else knew, I was able to fix it because I knew the root cause. The root cause is that tear right there. So I'm the first person in the world to repair tears in the disc, hence the first person to really officially cure back pain. So I use the same process of root cause analysis to figure out the source of back pain, chronic neck pain. It's given me the ability to treat it and cure it, right? Just like we used to have lots of water on the floor, didn't we? And you found the root cause to be what? A faulty system of collection, right? So you developed a new system of collection, which you've implemented, you've tested, you've perfected, right? You revised it, you changed it, you modified it, you reassessed it, and now you have an effective way of preventing leakage of liquids onto the floor. See, it's all the same. Whatever you do in life, if you find the cause, you can fix the cause. Problem is, most people aren't capable of doing that. I should rephrase that. Everyone's capable of doing it. Hold this here. Hold this right there. Don't let the tube twist. People just don't do it for whatever reason. They're not familiar with it. They haven't been taught to do it. I can tell you, I have one problem that I've never found the cause for in my life. That is Learning a foreign language. I can't learn foreign languages very well. I'm very slow. No matter how hard I try, how many times I read it, I just don't pick up on foreign languages. I've never found a cure. Right? The only class I ever got a B in was French. That's it. Everything else was A's. But I got a B in French, and I studied French more than I studied for all my other subjects in high school. Hein? Je parle un peu français, mais oui. I speak very little, but you're right. If I went to France and I lived there, I probably would learn it quicker, right? Either that or I'd starve to death. But I still don't have the root cause as to why I can't learn languages as quickly as other people. And it's not for lack of intelligence or lack of trying. I've tried. I've studied. I've gone to all the classes. I did all the homeworks, but I still couldn't do well in French. Meanwhile, my sister, who could never get an A in science, she wouldn't even study for her French test. She'd get an A. So she inherited my father's ability to learn languages. I didn't. I can't move this wire. You're holding it and keeping it from twisting. Can't do that. All right, we'll be done in 10 minutes max. We actually got lucky. We're able to get into this disc. This is a grade 2 spondylolisthesis. So for those of you who follow Duke Spine Institute's surgeries that we broadcast, some of you ask me, can you do this surgery for a patient with spondylolisthesis? The answer is yes, you can. Would you do a grade 1? Yes. Grade 2? Yes. Grade 3? No. Grade 3 is too severe. It's more than 50% slipping of the bones. This patient's right at about 50. So would I do a more than 50? No. I wouldn't. Let go. No, I wanted you to hold this here. Hold this. Yeah. Thank you. Now with a listhesis, you're inside the disc, but you could very easily become outside the disc very quickly. Why? Because when you have two bones lined up perfectly, you know where the disc is. It's easy to find. But once those bones start slipping on each other, then it's not so easy to find the disc anymore because the disc gets stretched. So on the vertebral body that the disc is attached to, where the disc is slipping forward, the disc ends more forward. Whereas on the vertebral body, that is more posterior to the compared to the other one, the disc is going to end more posterior. So you actually have to keep that three-dimensionality of the abnormal disc in your mind, combined with the positioning of the vertebrae and the size and location of the herniation. So it gets pretty complicated, three-dimensional processing. Let go. Of all the fields in medicine, neurosurgery requires the greatest amount of three-dimensional processing of information. The other specialties don't have anything even comparable. General surgery is close. Neurology, you have to have a pretty good understanding of the three-dimensionality of the nervous system, but not as much as a neurosurgeon does. Neurologists don't do surgery, therefore they don't really have to see the structures in a three-dimensional way the way a neurosurgeon does. 5 minutes. Neurosurgeons have to understand the three-dimensionality of all the nuclei, the tracks, we call them tracks, which are your axonal tracks. These are basically circuits inside the brain, and there's no red wires and black wires and green wires. You know, it's all white and gray. So we can't rely on color codes because there are no color codes. You have to rely on the old neuroanatomists that did experiments, and they were able to inject a stain into a nucleus and see where those fibers went, where they projected to in the brain. They did that by injecting dyes and then literally slicing the brain and spinal cord open, slice by slice, millimeter by millimeter, and following those stained tracks using fluorescence, and then writing it all down in like a map in a book. And it took a couple of 100 years to do. But that's how we built our understanding of the three-dimensional circuits that make up the nervous system. Almost done. But because we didn't get to do the dye injection, we don't have any blue. Right? You all notice that? There's no blue. So it makes it harder. Doesn't make it impossible. It just makes it harder. I remember the first time I couldn't get dye into a disc. It was just really quite an ethereal experience because everything was the same color. Didn't have my tracer, which is my dye. I couldn't see the tear with the blue dye. So I had to see the tear in my mind's eye and overlay that onto the anatomy that I was dealing with. Let me just see what I can do here without breaking the scope. Yeah, I think they did a good job with the scope, Luis. I can't tell, because the blue dye's not here, just how good of a job they did. I mean, what are your thoughts? You're seeing what I see, right? This is what I was talking about earlier. All this stuff here related to the inflammation from the tear. This is all calcified, like basically scar tissue, right through here.
Dr. Deuk, I have a question or a comment. Dr. Deuk, I have a question.
Sure.
It says, please describe the anatomy of the current scope view.
Well, all right, so at 12 o'clock you're having, what I'm zapping is something called the foraminal ligament, all right, which is contributing to the narrowing that's pinching his nerve. And then right where my laser is now, I'm inside the disc herniation. And I'm taking out as much of it as I can, but I'm limited based on my trajectory. The end plate of L5-S1 is right over there at 3 o'clock. The end plate of L5 would be at 9 o'clock, and I'm working between the end plates right here where there's scar tissue, where the herniation was. So I'm just slowly blasting little pieces off. And I'm not doing it slow for any other reason other than it's just not possible to do it faster because of the angle that I'm working at with the laser and the scope. So that's the back of the disc herniation right there, that white thing I'm blasting. Y'all see that? That's the annular tear. So again, normally we're used to seeing it blue because we inject the dye. Today we didn't inject dye because I couldn't get the needle into the disc space to inject the dye. So I have to do this without the dye, but this is all part of the disc herniation that I'm zapping away. To me it looks like it's been here for a while. This is not a fresh young disc herniation. That's a bone spur right there that I'm working on. It's gone now. I've done just about all I can do. I'm in a part of the spine called the lateral recess. That's the most common place you get stenosis or narrowing that pinches the nerves. So I've taken out the herniation in the lateral recess. Let's see what we've got. There should be a nerve root up here inside that fat. That's pretty much it though. We've done everything we can do. That's epidural fat. So laser out, laser off. That was the ligament flavum that I was zapping away at 12 o'clock. And that was the foraminal component. You understand? The part that goes into the foramen. Most ligamentum flavum is in the central canal, but a lot of people don't know it actually goes out lateral into the neural foramen, posterior to the nerve root. And then it buckles and it hits the nerve root in the back. So we were just zapping away the ligament to keep it from pressing on the nerve root from the back and pushing it against the disc herniation in the front, which we got rid of the herniation as well. Go ahead, push. We're done. Let me show everybody what we did. We did the entire surgery endoscopically through this little 7mm incision right here. Okay, we're going to put some pressure to prevent any venous bleeding, and I'll take any more questions. I'd say the EBO was 3 mils again. Yeah. Due to anatomical restrictions. All right, go ahead and write your questions up. I'll take them and answer them when I get to the conference room in a few minutes.
The pain level got to about an 8, a 9.
The right side of my body from the waist down was pretty much useless and in pain constantly.
The pain was chronic.
It was an aching, stabbing.
It became unbearable. It became where I didn't want to get out of bed. I didn't want to talk to anybody. I didn't want to do anything.
I had the pain every single day in my low back.
It's torturous. I can't go to sleep at night. I can't lay down. I can't sit for too long. Can't stand for too long.
I couldn't sit. I couldn't stand. I couldn't walk more than 50 feet.
It's excruciating.
Sends excruciating pain across my back. Gets down to my hands where my hands are numb.
I had no life.
If you are suffering from neck or back pain, the Deuk Spine Institute can give you the relief you need to live your life without pain.
Now I have absolutely no pain.
Not even 24 hours after the surgery was complete, I was able to be how I felt is normal. And it was good.
No scars, didn't hurt at all. As you know, when I woke up, it was totally painless.
The next morning, I was up and about and out, dressed on the job.
I have no pain. I'm living my life and doing great things, and I'm just very happy.
It's a great feeling not to be in pain.
Deuk Spine Institute has changed thousands of lives. Isn't it time you live your life pain-free? Log in to DeukSpine.com or call 1-800-FIX-MY-BACK for a free MRI review and consultation.
I feel like a new man again.
And it's thanks to Dr. Deuk. He gave me my life back.
Dr. Deuk did an amazing job fixing my back. I recommend him highly to anybody who has any kind of back issues, any kind of back pain. Don't wait. Go see him. The relief is amazing.
Dr. Deukmedjian. All right. So for those of you watching, we just finished a left-sided L5-S1 Deuk Laser Disc Repair. This is a state-of-the-art, most advanced spine surgery in the world for a herniated disc. Unlike traditional surgeries, there is no bone that's required to be removed from the spine. Other surgeries that could be done, microdiscectomy. Microdiscectomy is a bigger incision, muscle damage, bleeding, higher risk of infection and complications, and most importantly, the surgeon is going to take part of your spine out to get to the herniation. Second most importantly, microdiscectomies don't cure back pain. They only cure or treat leg pain. And they can cure leg pain if they're done properly. Many surgeons don't do them properly. So what are the disadvantages of the microdiscectomy? Doesn't cure back pain. This patient has back pain. Most people do. They don't get rid of their back pain. Number two, bone is removed from the spine, thus weakening the spine, and you're going to end up needing a fusion. Whether it's a year from now or 2 years or 5 years, you'll end up needing a fusion at some point, at least 50% of the time. So it's a bad surgery for destabilizing the spine. And then, of course, more bleeding and higher complication rate. Another option, laminectomy. Laminectomy is where you go in and remove bone from the back of the spine. You leave the disc herniation there. It's probably the worst of the treatments. It only fixes neurogenic claudication, may help with leg pain, does not fix back pain, and also destabilizes the spine even more than a microdiscectomy. And then, of course, there's fusion. You could go in and do a decompression and fusion, take the whole disc out, remove the herniation, and then put cage and bone graft in the inner body space, pedicle screws, rods, and stabilize the spine so there's no more movement at L5-S1. That would be an option for this patient. That would be this patient's second best option, given the fact they have a grade 2 listhesis or slippage. You wouldn't want to do a microdiscectomy or laminectomy, but most people don't have a grade 2 slip. They just have a regular old herniation, and they don't have any instability of the bones where the bones are sliding or moving. So this patient had a spondylolisthesis, so we would want to do a fusion if we were doing open surgery. Then there's Deuk Laser Disc Repair, what this patient had. Endoscopic surgery, and the surgery is done with a tiny little cut. It's the smallest incision of all spine surgeries, and there's no bone removed. We're going from the side, so there's no removal of the lamina, there's no pars removal, there's no removal of the facet joint. None of the bone things in the spine that hold your spine together, they're not touched, because we go through a natural hole that's already there, so we don't have to make a hole in the spine. Most spine surgeons, all other spine surgeons for that matter, have to make a hole in the spine to get to the disc herniation. We don't have to do that with the Deuk Laser Disc Repair. Any endoscopic transforaminal surgeon, a surgeon that uses an endoscope and goes through the neuroforamen like I did, none of us have to remove bone, okay? All of us have that advantage. What separates the Deuk Laser Disc Repair from all other endoscopic spine surgery on the lower back is that the Deuk Laser Disc Repair incorporates an annular debridement. Annular debridement means I'm using a laser to clean up the annular tear. No other spine surgery in the world cleans the annular tear up. The endoscopic surgeries that are currently done by other surgeons remove herniations but don't clean the annular tear. So they only treat leg symptoms, they don't treat back pain. By debriding the annular tear, you're now doing a Deuk Laser Disc Repair if you incorporate into your endoscopic surgery, and you're going to be able to get rid of the neck pain or back pain depending on the part of the spine you're operating on. So neck pain is due to an annular tear, back pain is due to an annular tear. So to be able to get rid of the discogenic, which means it's back pain coming from a disc, you have to debride the annular tear. If the patient has 2 painful discs, you have to do 2 disc annular debridement. If they have 3 painful discs in their back, you have to do all 3. Otherwise, they're still going to have pain from the disc that you don't treat. The only way to get rid of disc pain is 2 things. Number 1, Deuk Laser Disc Repair, debridement of the annular tear. Number 2, clean the whole disc out with shavers and then fuse the bones together. So will a good fusion work to get rid of back pain? Yes. Will a good fusion work to get rid of discogenic neck pain? Yes. But why would you want to do a fusion when you could just do the endoscopic laser surgery, a very fast recovery, minimal pain? This patient will take probably Tylenol for pain, and that's it. If you're having a microdiscectomy, a fusion, or laminectomy, any of the other surgeries, you're looking at being on narcotic opioid painkillers for weeks, if not months, while you recover from the surgery. And the reason you're taking those painkillers is because of the surgery you had. It's not because of the problem you had before surgery. It has nothing to do with the herniated disc. It has nothing to do with the actual fusion. It has everything to do with the approach, how the surgeon gets to your bad disc and fixes it. With open back surgery, you have to peel the muscles off the spine. That causes horrible inflammation in the muscles. It causes muscle spasms and muscle pain. That has to be treated with powerful narcotic painkillers and muscle relaxers, which is why people who have open back surgery end up with so much pain and they need to be on powerful painkillers, is because the surgeon basically caused pain from inflammation in their muscles that they had to move out of the way in order to get to the spine. With the Deuk Laser Disc Repair, we're not causing any muscle pain because we're not moving the muscles out of the way. We're not doing an open surgery to move the muscles out of the way. We're literally just spreading them apart, and then when we come out with the tube, we're putting them back together. They actually go back together on their own. So there's really no muscle trauma, which is why there's no need for painkillers after the surgery, except for Tylenol. All right, since there's no questions, right, I'm going to go ahead and wrap the surgery up. Have a great day. Nice talking to you, and we'll see you hopefully next